So this is, I brought my pelvis because I feel like, I don't know. Again, this is just a gray space. Everyone has seen a pelvis or like, a skeleton on like a Halloween skeleton. And it's just like a dangly thing of bones, right? Yes. But like nobody really sees it with like the pelvic floor inside. And it's sort of like, oh, I didn't even realize that was there. So anyway, so in my, in that first visit, we talk again, symptoms, talk about, what their goals are with pelvic floor PT, how pelvic floor PT can help. Mm-hmm. And then I bring out my trusty pelvis. So those of you watching can see this. But this is just literally one of my favorite things to bring around. This is like...
kind of cute.
I know, thank you. I think it's really cute.
So walk us through as best as we can. Maybe we can use some like visual context clues so that if they aren't looking at it, they can get an idea in their head. But what are all the parts? Lay them out.
I love it. So first off, we'll start with a little bony anatomy. You're just going to hear my PT self come out right now. But basically, these two big bony wings of our pelvis, like when you're angry, you put your hands on your hips because you're like angry. Mm-hmm. That's like right here. You're like, we all know that. And then these two bony wings are joined in the middle here by your pubic symphysis joint. So this is a big joint right in the front here. It's like kind of below your belly button. In the back here, we've got your sacrum, this kind of big guy right here. One SI joint, the other SI joint on the other side. You got two. And then we've got your tailbone, this little guy right here. It's like actually like literally like this small. And then you've got your spine stacking right on top of everything else.
Do you know what's so interesting is that I really always thought sacrum and tailbone were sort of the same thing.
So the tailbone's connected to the sacrum, but yeah, they're actually like connected by joints.
So every time that I have hit my sacrum and I said tailbone, I was wrong. Like that's good to know.
Totally.
What's what? See, learning so much already.
Your mind is about to be blown, Tracy. So then, so that's all the bony stuff. And then in the middle here, where's the camera? Oh, right here. So this little bowl right here of red, those are your pelvic floor muscles. So everyone has them, male, female, anyone in between, young, old. We've all got pelvic floors. Genitalia is obviously different for all these people. But anyways, you can think of this pelvic floor as sort of like this muscular basket of
it does look like a basket.
Yeah, it's a little
like
basket.
A bowl basket, yeah.
Exactly, that supports all your pelvic floor muscles. All your pelvic organs. It's a bowl of muscles that supports all those organs. So this is going to be a cis female here, and then I've got my little organs here. I don't know if you can
bladder
right here, this little guy. Wow. The urethra goes out here.
That's little.
I know.
Is that how big our bladders actually are?
Ish. It expands quite a bit more. We'll talk more about bladders. I know you have a lot of questions.
Oh, yes, we will.
This little guy goes right above, actually right behind the pubic bone, just right here. Lives right here.
Okay.
Then we've got your uterus right here. This little guy here, which obviously gets much bigger.
So describe the shape of the uterus.
Oh, that's a good it's kind of...
It's giving me elephant ears and nose.
So if you think of the elephant ears as where the fallopian tubes are, and then the head of the elephant is here, minus no nose. Don't think about a nose, an elephant nose. Oh yeah, I forgot this is a podcast.
Yes.
I'm pointing things out. Uterus right here. And then if you can imagine the cervix right underneath the uterus and vaginal canal right here. This goes above and behind the bladder, just like this, kind of tucked in here.
Okay,
so you can see it's how do you
uterus? Your uterus essentially sits on top of your bladder.
Basically, yep.
Okay.
And then your vaginal canal sits right behind your bladder.
Interesting.
Yep. And then guess what? We've got our friend the rectum. Boom, right
Hello,
here.
Old friend. Or are you my foe? We'll find out when we further discuss.
But anyways, front to back, we've got your bladder, uterus and vagina in the middle, and then rectum right in the back. So explaining this to people can be really enlightening because they can be like, oh my gosh, I didn't realize that was right on top of that. Or this was right behind this. And that makes sense that some of my symptoms are like that.
Close quarters. And it gives a really good visual of why perhaps, not for every single one, but for, some issues with your bladder, how that could affect your reproductive organs versus your bowels. You know what I mean? Yep. So I think seeing the relation and proximity that they have to one another, makes it all sort of make sense, right? Okay, well, obviously they're going to affect one another. They're all crouching on top of each other.
In this tiny little bowl.
Tiny bowl.
Yeah. So just like as an example, folks that are really constipated a lot of times have a lot of urinary urgency because guess what? That poop is taking up a lot of room and it's squishing into the bladder, and the bladder might not have enough room to fill a lot. So then you might have a lot more urgency because you just don't have your bladder doesn't have room to hold more pee. So this is why we like ask all these questions. Some of it, again, seems very TMI, but it actually helped us just kind of get to the root of the issue also.
Yeah, I know, which is really great. And I also want to just say the way that you describe everything so far, I mean, I can already tell you have exceptional bedside manner, which is so important, especially for something like this where it's a little uncomfy, it's new for people, they're not totally even sure why they're here a lot of times. And you have such a really great way of being informative, but also even just like the tampon thing, you're like, you don't want to use it? No one cares. No problem. I think that you just make people feel very comfortable. So you have really, really great bedside manner while also being extremely informative. I love it. I could listen to you talk about this all day.
I appreciate that so much because it is so important to be able to connect with people in a certain way, but also be able to give them information, but not make sure that I'm not just talking at them. I want to make sure they understand they're part of the conversation.
Absolutely. And what you're saying is very reminiscent of, for me, I've talked a lot on the show before how I've been really into functional medicine and holistic ways for care. And part of the reason behind that is because I think that a lot of times it can offer more of a 360 lens, and rather than, oh, my belly hurts, and they go in and they only focus on your belly at your PCP, right? And they don't look at, well, what other things could be going on here? So you have that same approach where I know you're coming in because of your bladder, but let's see all the different angles, what else could be going on, because it might be like a domino effect happening here. It may not be the root at your bladder. It may be coming from somewhere else, and now your bladder is just sort of suffering because of it, which is super important. You go that extra mile, and I think it just makes people feel really at ease. So I love that as well.
Perfect. I love that. Yeah, I feel like we're like little detectives. We're just trying to help and figure out.
Put your PI hat on, girl.
I'm not done with the pelvic floor though. We haven't even gotten to the pelvic floor, to be honest. So I'll try my best to explain for those who are not watching. But this is the pelvic floor again, in a cis female here. But hair, skin, fat is all trimmed away. And again, it's like we're looking at some red things, aka the muscles. Mm-hmm. Everyone's got 3 layers to their pelvic floor. Who knew? 3 layers.
Talk to me.
I know. Okay, so just to orient you all a little bit, I don't even know if you can see, but we've got the clitoris.
We're looking at a male vagine, vulva area.
Female.
Sorry. Did I say female? I mean, did I say male?
I think you said male. No, but female.
Yes.
We've got your clitoris right here, urethra, vagina, and your rectum. Sorry, I can't see. These 3 holes here. Boom, boom, boom. And those obviously correlate with the bladder, the uterus and vagina, and then the rectum down here. First layer of the pelvic floor, I'm not going to point it out, but I'll just kind of speak to it.
Yeah.
The first layer of the pelvic floor sort of overlays the clitoris and the bulb and glands of the clitoris. And it's actually really responsible for sexual functioning and arousal. So the pelvic floor actually has a huge role in that. It has a little bit of role in urinary control too, but again, mostly sexual functioning. Second layer, you really can't even see it here, but that actually wraps kind of around the urethral sphincter. And that's more for like urinary control, but that's more like almost like involuntary. So like you and I are sitting here, but you're not thinking about like, oh my God, I'm not trying not to leak. You're not squeezing anything. So something's keeping you continent right now. You're not just like drip, drip, drip right now. Mm-hmm. And then the deepest layer.
And for them at home, continent means?
Oh, sorry. Not leaking, staying dry. And then the deepest layer right here. Have you heard of Kegels?
I have.
Yes. This set of muscles is most responsible for those Kegels. The other ones do it too a little bit. But you can think of Kegels as
and those are in the inside?
Yes, they're the deepest, thickest layer. And you can think of them as sort of, it's a pelvic floor contraction. So when it squeezes, it lifts everything up. That's a Kegel. So example, if you're in a really crowded elevator and you don't want to fart, guess what you're doing? You're trying to Kegel. We've all been there, right? You've been in a meeting, you've been in a crowded elevator, you don't want to fart. It's not just your butt cheeks moving.
I was going to say, I thought you were trying to squeeze the sphincter.
Yeah, but like
you got to do a Kegel, I guess. Yep. Yeah. Yeah, yep. I never thought about that.
Are you trying right now?
Yeah, obviously.
I know. I hope all of you at home are like, wait, where is that? So it's not just, honestly, if you're squeezing your pelvic floor, I shouldn't be able to see you moving.
Okay.
So you're not just doing like butt squeeze, like glute squeezes. What was I going to say? I lost my train of thought. Oh, yeah. So, but the thing is about Kegels is like, we don't want to just squeeze all the time. Because if you're squeezing all the time, you just get really tight, right? You're never just going to do like bicep curls and only bicep curls. You're going to do your triceps too. Like you want to do the other side. But you also want to make sure that you can do pelvic floor relaxations so that when you're actually pooping and you're actually peeing, you're not so tight that you're holding things back. When you're actually having anything penetrative in your like a vaginal intercourse, guess what? You want to make sure you're able to relax and allow something to come in versus just kind of close it off.
Right.
So it's, I would say almost equal. I would say they're equally as important: the ability to contract as well as the ability to relax.
So there is potentially a downfall. Like you can do too many Kegels. It's not one of those things where you should just be doing it all day, every day, no matter what.
Probably not.
Okay. Good to know.
Yeah.
Because I think you hear about it all the time, right? And people think that that's
it's the end all be all.
Like you're working out, like that's me getting it fit. So it's going to be in the best shape if I just keep doing it consistently. But you may lose that inability or that ability to relax if you do too many.
So Kegels are not inherently bad. But the way that most people do them is that they just squeeze, and they forget to relax at all. So if you can do a Kegel and relax fully, great. Again, I would hesitate to tell somebody to just do 100 a day. Like I would probably never tell anyone to do that. But I know there's a lot of stuff out there that say like, you want things tight. But it's like, yeah, that's not always the best thing.
Yeah. Well, when you explain it in that way, it makes complete sense. Totally understand that. All right, what else do we got in this little diagram? Is that everything?
So I think that was the 3 layers of the pelvic floor. Oh, I was going to talk about, we were talking about like the first visit. Then usually I tell folks what's an exam look like?
Yeah.
Like, what
is a pelvic, like a physical exam of the pelvis necessary? Is that required?
So an internal assessment, either a vaginal or rectal assessment, not always required. I would say that it should always be offered, or if we don't know what's going on with the pelvic floor, that should be offered by the PT. It does not always have to be, if a patient is uncomfortable, they want to save it for next session, or they never want to do it, that's on them. Like, that's perfectly fine. I do think it's really helpful to be able to see like exactly what is going on in there.
Yeah.
Because like some people really think they're doing Kegel, but they're doing it really wrong. Or they're like, you're telling me to relax things, but like, I'm not really sure what I'm doing there. So doing that internal assessment can be really helpful. But again, it's really patient preference on that point.
Yeah. Question on that too. The internal assessment itself, is it a combination of visual, like looking around and seeing if everything looks to be quote unquote normal, but also feeling around is, are the muscles super tight or the organs, how's everything sitting and placement? Like what are you doing in the assessment itself? You're not just looking, you're couple different things, right?
Love it. So even before I do the internal assessment, we'll usually do an external assessment. Like, how are you moving? Can you do a squat? How are your hips moving? Like something external too. Because again, everything's connected. I'm holding up the pelvis for those of you who can't see. Literally everything's connected. What's going on outside will affect what's going on inside and vice versa as well. But, so the assessment, usually I ask patients, I'll step out, I'll ask patients to get changed. There's no speculum or stirrups, so usually it's a lot more comfortable for folks. Like you're not getting like a metal speculum jammed up there.
Lovely.
Horrible. I know, right? It's just like, that like, oh, it's terrible. Terrible for all. So the no speculum or stirrup, so just using a gloved, lubricated finger. And then on first exam, we'll just look at the external vulva. Just kind of seeing, how's the skin looking? Is it irritated? Does it look dry? Do things look atrophied? Is there an infection? Just kind of getting a lay of the land and kind of seeing what's going on there. Do we have hemorrhoids? Like, do you have a scar from childbirth? Like, what's going on here? And then we'll dive into, we'll kind of touch around and kind of feel all those different areas. And then we'll do the internal assessment. So that's just like one finger going in vaginally, if we're talking about a vaginal exam. And then we'll actually be able to feel all those different layers of the muscles, like even right to left, kind of seeing what is going on. Maybe one side is a little bit tighter, another side is not so much. Maybe pressing on with one specific muscle brings on your like nerve pain. Or somebody's like, oh my gosh, when I'm trying to have sex, this is what that feels like. It's so painful. Then we kind of know a lot more information about that.